All right, guys, at this time, we're going to go ahead and start with our didactic, and that's going to be from Miss Katie Chiasson-Downs. Sorry if I said that incorrectly.
Katie, you got Katie great, so that's good. Let me
All
see
right.
if I can you all see my slides? I see head shakes, yes, great.
Yes.
All right, thanks so much for your time. I try to present on ethics a couple of times each year. The presentation typically repeats a couple of the first initial slides just for new folks that have joined our ECHO group over the year. In the interest of time, there's a few of those I might go pretty quickly through or even skip, so we can really just get to the kind of open discussion at the back half of that. And what I've done is highlighted a few dilemmas that either I've encountered recently or I have heard from our kind of greater ECHO group ethical dilemmas that you all have been navigating. So that'll be the sort of new back half of this presentation. As usual, my farm animal assistants at home will be assisting me in teaching you all about ethics in a cute way. So the field of ethics involves developing, defending, and then recommending concepts of right and wrong behavior. And so with ethics, what we're looking at is the nature of individual good and the nature of social good, and then how those two interact or relate with each other. We're looking at what are the motives that exist for the individual to pursue that social good or whatever they consider morally right. And so in modern ethics, this is about us determining what our duty and kind of moral obligation is. Thankfully, the ethical codes change over time in response to how our society changes, which then affects how our laws change, our training changes, and how we change in response to these dilemmas that we're faced with. So each of us in this our ECHO Zoom room here, we all have our own separate professional code of ethics that we're required to follow. And so it's on us to know what our ethical codes are, to know the codes to begin with, to know when they've changed, and to also understand how our personal values fall in line with those codes that we're required to follow in order to keep our license. Sometimes your personal values may not align with your professional ethics. So then the question is, what do you do? Who do you lean on to help you make that best fit ethical decision in the moment? And then an additional tricky area, it's challenging, but I think it's a good challenge, is what happens when your values and ethics don't align with the values and ethics of other people on your treatment team? The majority of us on here work in multidisciplinary treatment teams. And so how do we as a team come to make that decision or make that agreement about what's the best decision? It might not be the right decision, but what's the best fit decision? These two slides I'll go through quickly. So the 4 keys to an ethical practice, this is what helps our foundation with our healthy practice. And so honoring these 4 keys helps us with that. We all want to recognize what our strengths and limitations are and lean on the experience and the support of the folks around us. We want to respect the tiers of ethics, which I'll go over in the next slide. We want to seek continuous learning, exactly what we're doing now. I just learned something from the case presentation that Laura gave. Thanks so much, Laura. And that we want to do is sort of make our rule. It's about establishing that norm of behavior against which exceptions may end up occurring. So again, we're in the process of making that ethical decision. We're looking at these tiers. And it goes from top to bottom. Tier 1 is the federal level. This is the highest tier. This involves those federal statutes that must be carried out by all states. And tier 2 is the state level. We then have our personal licensing or credentialing level, our own agencies level, and then again, our own personal belief system. I think in past ethical consideration presentations, I will typically highlight the American Counseling Association's Code of Ethics. That's one of the 2 ethical codes I follow, but I also follow NADAC, so I want to give them a shout out today. So certified drug and alcohol counselors adhere to the NADAC Code of Ethics, which were most recently updated in 2021. For any of the counselors on here, our code of dated in 2014, which is a bit of a problem. So hopefully they change that soon. And in their code of ethics, they recommend considering these 17 standards when making a decision. If you have the ability to maybe take a screenshot of it, because we'll come back in our sort of discussion later. We'll come back to talking about which of these standards do we think are interacting with each other in a dilemma. I won't read them all out loud or go over them, but just take a look at them. You're going to recognize some categories that are probably in your own professional code of ethics. And what I also love about this list is there's a lot of ones on here that are really similar to the virtues of the greater, recovery movement and recovery community. You've got gratitude on here, which I think is beautiful, and that's not necessarily in everybody's code of ethics. To my next. Oh, I need to pull this up. So technically, what is an ethical dilemma? It's a challenging situation in which it's difficult to decide on the most appropriate or most ethical course of action. And so often in these situations, you're going to have multiple principles that are at odds with each other. And so to meet the need with one, you're going to have to compromise another one. And in these situations, it's often difficult, if not impossible, to make the absolute right decision here. It's really about making the best fit situation in that particular case. But just so you know, the chickens, their ethical dilemma was deciding whose bowl to eat out of, and they went with Spork. Even though he's got tusks, he's a lot nicer than this gal over here. So again, hearing from you all as a group, hearing from our ATI community, we had our ATI conference last month. These are the suggestions that came up. And so these will be the kind of three we're going to highlight this afternoon. So we'll talk about peer recovery support specialist dual roles. We'll talk about scope of practice, and we'll talk about mandated reporting. So we'll start by talking about our peer colleagues. So our peer recovery support specialists also have their own ethical code of conducts. I've brought this to the table today. Again, at ATI, this conversation came up a lot. We were grateful to have PJ, who's here. He sat on a panel for us, and the dual role came up a lot in the community, or I'm sorry, in the audience. And the peers in the room were really clear about what their boundaries were, but some other folks in attendance weren't. And I can appreciate it's because a lot of them don't get the opportunity to get to work with peers regularly. So it was a reminder to me, we probably need to talk about this a little bit more. And so the general question was, when do peers report to the team or to the authorities what they're hearing or seeing with clients? And so the question is, when are there times in their life when they get to take off that peer hat? If you notice, I've chose that picture for PJ because my pig's wearing a hat. So as more agencies are blessed to work with the opportunity, to have the opportunity to work with peers, we're really trying to manage and learn about those dual relationships. It feels like a new situation's popping up every month. And we kind of, as a team, have to talk about, okay, how do we navigate this? And so again, peers do also have their own code of ethics. They abide by the NCPR-SS code of ethics, which is under that NADAC umbrella. The code itself isn't necessarily as detailed as some of the other licensure codes, and it's a bit broad about requirements. But within that code, peers are instructed to abide by their agency policies, which means that for the peers, what they want to do is get really clear with their treatment team, and their treatment team wants to get really clear with the peers on what's to be expected with them. When they're talking with patients outside of group therapy, what are they going to keep confidential and not keep confidential? When they see patients out at peer recovery meetings, what are they going to keep confidential and not keep confidential? So just to be clear, if your peers are members of any peer recovery communities in town, for example, if they go to Alcoholics Anonymous meetings or if they go to NA meetings, they're expected to follow the confidentiality rules of those meetings. So when peers are going to those meetings, they're taking off their peer hat in terms of their role in the treatment team working for your agency, and they are there as a community member. And while maybe those meetings, those confidentiality rules, they're not laws, but they're vital to the integrity of those communities. So it's really ultimately up to your agency how you decide to involve the peers in the treatment aspect of your program. And so within our agency, our decision is that peers are a member of that, they're an official member of the treatment team, in addition to acting as that liaison for the patients in the community. And so we inform the patients of that ahead of time, of what their involvement is and where their confidentiality starts and stops. And so we tell peers that if they happen to go to a peer recovery meeting and they see one of our peers in there, that information that they share in there is going to be confidential. And they also inform them if there's any dual relationship, you know, when they get assigned to a group or assigned to a team and peer that they're working with in a different capacity, let's say the peer that's assigned to their therapy groups also happens to be their house manager at their sober living home, we want to assign them to a different treatment team because we don't want to put patients in the possibility where they're going to be feeling forced to not be able to be super transparent about things that are going on. So here's 2 case examples. I'll open the chat box so we can, please feel free to unmute and give suggestions or put in the chat box. So the case example number 1 is a peer working in your agency sees one of your MAT patients at a meeting and the patient discloses a relapse. The patient then does not disclose that relapse at their next clinic appointment, which the peer sits in on. So what ethical principles are at odds with each other and how would you all handle it? And again, feel free to unmute yourself or just jot down some answers in the chat box, which I'll open. We'll start with that first question. What are some principles that are odds with each other here? I would say confidentiality is one. And what's that kind of going up against? Maybe honesty? Or versus loyalty versus autonomy? Loyalty to the patient versus loyalty to the program? Yes, Laura, loyalty to the program versus agency. Great. Joy said the peer can encourage the patient to be honest after the meeting, but it is not the peer's place to disclose it to the meeting. Joy, so well said. That's our role. We can encourage them to get to the place where they can share that information, right? But we can't do that work for them themselves. So Joy, so well said. Yeah, Laura, great point. Client confidentiality, loyalty to the client. Would the case change? Oh, go ahead, please.
That's always going to be my go-to in cases like that, where if I'm at a meeting and one of the folks in my code group discloses a relapse at that meeting, you know, I'm not going to take that to the treatment team. You know, I might sit down and have a conversation about honesty with that patient.
Yeah.
And say, hey, you know, I noticed that you didn't mention that today. You know, what's the reason behind that? And let's have a conversation about honesty and how important that is.
Yeah. Well said, PJ. Thank you. Anybody else do anything different with that first case? Going once. What?
Katie, I don't think I would do anything different, but a different scenario would be if the PRSS is leading a peer support group at the agency. I mean, that's what happens here is our PRSS leads. It's not, so he's not out in the community hearing something. He's in the group where he's leading as a member of the treatment team. So it sort of puts a little extra torque on it, although I don't think it changes the need. In our experience, we don't expect him to report what, you know, we expect that he won't report what's disclosed in that meeting.
Jennifer, oh yeah, go ahead, please.
Yeah, so that.
Yeah, great point that some details can change how we handle it, right? So if a peer is running, and here's the thing with meetings and groups, my gosh, those 2 words get used so interchangeably with patient, right? A therapy group is different than a support group meeting, but we will use them interchangeably. And sometimes when we're talking about the rules or confidentiality of one, it's good that we need to be clear with patients of, I know we're talking about these groups, but these groups over here is a little different. So sure, if PJ is in my group therapy session that I'm running at work and he's co-leading it with me, or he's leading it himself. If it's a meeting that's sort of sanctioned by the agency and frankly he's billing for, that would be a treatment team meeting. And our expectation to the patients is what gets shared in that space. If it's, you know, sort of pertinent to your treatment goals, that will get shared with the treatment team. However, if PJ is, you know, facilitating an after hours mutual aid meeting, you know, an AA meeting, an NA meeting type of thing, even though it's taking place at our agency, we would say that that's separate. And what's taking place in those meetings is really separate from the treatment team's goal. But so Jennifer, great point that how your agency handles those needs to be communicated up front. Very well said.
Also, to get around that confusion, because I find that people get very confused about what's a meeting and what is group. So I've started calling medical and group medical and group counseling appointments. I don't call them meeting or groups anymore. I say it's your medical group appointment and your medical and your group counseling appointment. And that I try to help people
That's
out.
so helpful.
Particularly at induction, people were just like, what? When do I come to meetings? How many?
Right. Yeah. Oh, Jennifer, so helpful. Thank you. And it's a great reminder of like, these are medical appointments that they're attending. Yeah, really helpful. The second case on there, so a peer working in your agency sees a patient in their car in the agency's parking lot. The car is running, they appear intoxicated, and they have a child in the car with them. What would y'all do? In that case, does the peer have their hat on or off?
I mean, I can answer that as a peer.
Sure.
A peer, I'm going to have my hat on in that case. You know, because that comes down to an imminent danger to themselves, that child, and the community if they're driving that vehicle impaired. You know, and I have a duty to report that.
Yes, well said, PJ. Right, so that, you know, they came to work, imminent danger, right? We're going to talk about mandated reporting in a little bit. That's the, you know, they're showing up for their appointment, as Jennifer pointed out, and that would be a thing we want to report.
Yeah, and
Right.
you know, because they're at my place of employment for that appointment, and you know, I'm actually at work, so
yeah,
you know, that's one of those places where I leave my hat on.
Yeah, great point. All right, good work so far. I'm gonna see how fast I can go these next ones. Let's talk about scope of practice for the non-prescribers in this group. So, you know, I think I've said this before. I'm really biased about, I really believe, I think the addiction field is one of the best fields to work in as an addictions therapist. I think the multidisciplinary treatment teams we've been able to work with, they're just so incredibly inclusive with having us all be a part of these bigger team discussions for our patients. We have the opportunities to learn so much from each other. Sometimes I think even more so than therapists that are out there individually on our own. I will say, for all the great work that I see our therapists, counselors, peers, and case managers do, the area I've seen us kind of go astray with the most is really the topic of medications for opioid use disorder. What we can do as non-prescribers, as professionals, is recognize that a patient meets the criteria for opioid use disorder. We can educate them on the options available with evidence-based treatment, and we can educate them on the mechanics of how medications for opioid use disorder work. But it's not our place to instruct patients on dosage changes. It's not our place to share our opinion with them on when we think patients should be stopping the medication. And furthermore, I would argue it's not ethical to have and share the opinion with patients that patients utilizing medications for opioid use disorder aren't truly sober. You know, that opinion's not backed by science. It's not backed on any kind of evidence-based model, that this is a part of their treatment plan that is recommended to them by the other medical providers on the field. So, you know, for example, if a patient's asking me, what's just the educational difference between Suboxone and Subutex? Well, sure, I'm going to talk about that. If a patient's telling me that they are thinking about starting to taper off their medication, I'm going to encourage them to talk with their medical provider about that. I don't want to kind of share any personal opinion about whether I think they should or should not be making changes to their medication. So a couple case examples. So first one, a patient of yours has achieved 3 years of continuous sobriety. They have stable employment. They're in a healthy relationship. And in a group therapy session with you, they share they are ready to begin tapering their medication for opioid use disorder. And the other group members start to provide some how-to tips. So the other group members, boy, they're well-intentioned, but they start telling them exactly how they should go with that process. The therapists, counselors, social workers on the call, what would you do? Let me open that chat box. I lost it. Question is, do you sit back and just sort of do nothing and go, well, this is the group talking, I don't want to interrupt? What would you do?
I would try to maybe like shift the, like, appreciate like the everyone is like willing to give help and, you know, really recognize that, but shift into like you said, refocusing on just what Joy said, encouraging the patient to talk with their prescriber, and refocusing kind of the conversation that is a little less how to.
Yes. Oh, Joshua perfectly said, a great therapist reframe. And thank you, Joy. That was great. Yes. What we want to do is, you know, we appreciate Nilla jumped in as well. Excellent suggestions. So yeah, we want to thank them for, you know, trying to meet their group members where they're at and provide them support. I love that. And they're trying to help them with encouragement. And we want to provide them those gentle reminders that they need to be talking with their medical provider. And what we're not here is in group is sort of to tell other people what to do. We can show up with them and sort of share our experience, but not necessarily give how-to tips. Great job. Second case on there, a patient calls in and expresses continued cravings. During the last treatment team meeting that you sat in, the prescriber stated that they did plan on increasing the patient's dosage in the future if their cravings didn't stop. You can't locate the prescriber after the patient calls, but you do call in scripts on their behalf to the pharmacy when they've approved them. So what would you do here? Nope, don't touch it. That's a great answer, Calor. And that is the correct answer. Yes, that is not in our scope of practice. So that's not one of those like gray area, what's the right fit decisions here. It is not in our scope. So great work. Okay, last one. Let's talk about mandated reporting. So, I lost my slides here. Let me tell you, the mandated reporting codes, they have these little squirrely S's before the numbers. And for the life of me, I could not copy and paste those or come up with those squirrelies in the text here. So just imagine that they're there. So mandated reporting, listen, this is a heavy responsibility that all of us in our Hollywood squares here carry. So in the state of West Virginia, anyone is able to call and report suspected abuse or neglect of children or vulnerable adults, which includes, you know, folks staying at facilities. But there is a long list of people in the state that are deemed mandated reporters, which is our ECHO group here. So any medical professional is a mandated reporter, which means that when we suspect childhood abuse or neglect, we need to make that report within 24 hours. When we suspect it for vulnerable adults, we need to make that within 48 hours. Now, where people differ in their thinking is when and how addiction affects people's abilities to be safe and keeping other people safe. So we have to remember that substance use does not automatically mean that that person isn't safe. If that were the case, we'd have to report every single person that leaves a restaurant after they have a drink with dinner, or we would have to report every single patient that's leaving our agency and we know that they're getting ready to drive, or every single patient that is a parent and they take an opioid post-surgery, they've got kids at home, or every person with a panic disorder that takes a Xanax when they're out in public. So that same thinking can be sort of kept in mind for people that are misusing substances or using substances addictively. If a patient reports to me that they've relapsed on, let's say, methamphetamines this weekend, I can't go straight to the assumption that they have used around their kids, or they've used while driving, or they've used while they're on the job. And I can't assume that they're using all the time. If I do that, what I'm doing is criminalizing their disease. So our licensing codes in here should give us examples on when to break confidentiality and to make that report. I know we won't have time to go over it. At the end of this, there's a decision-making model that what you can do is use in the context of your own supervision or consultation when you're faced with, is this something that I should share or not? And so ultimately the ethical dilemma is that we're sort of at odds with, we want to do no harm for the patient and then also do no harm for the community around them. Kelly, I see what time it is. I'm really sorry. I'm going to go fast. So case example number 1, you work with a patient. They're a CNA in a skilled nursing facility. They've admitted to relapsing a few times on methamphetamines recently, but they haven't reported whether they've used at work or not. Is this something that you believe is reportable? Let me open. I keep closing my chat. So we think about the ethics that are at odds here. We've got confidentiality versus non-malfeasance, loyalty to the patient versus justice to the community. And so does anybody sort of have thoughts on what you would or wouldn't do here?
I don't know that you put their job in harm until you're sure that it's taking place in the workplace or before they go into the workplace. It's going to affect them from doing their job. Well
said, Kelly, right? We can't make assumptions. Joy said it also well in the chat box. Have you noticed any misdoing by the patient? If not, then you can't report them. Correct. Number 2, you work with a patient that is a CNA in a skilled nursing facility. They admit to you that they have been diverting their patients' various medications and are in active addiction. Is that something you'd report? I see a lot of head shakes. Yes, that is something that we would report. And what we want to be careful is that who we do and don't report that to, we report that to the reporting system within the state, right? So what I wouldn't do is call, I'm going to use Joshua as my fake patient. I'm not going to call Joshua's boss up and say, I need to let you know something that he shared in therapy. There's a separate state reporting system that we would use for that. And it's allowing that department, that agency to be doing the detective work to really figure out, to go forward with that complaint. And that's not really on us. Boy, I really took us up right up to a minute past 5. So these slides will go, when Kelly sends them out tomorrow, here's that sort of model of a ethical dilemma decision-making model that we use. This isn't one specific, it's really just taken from a couple of other different models out there. And always want to remind you all, for ethical dilemmas, we're all going to make mistakes in here. We can't help everybody in the moment. We can't also be expected to know everything. We can't do it alone. That's why we got to rely on the support, the supervision, the consultation of the folks around us. And there's references at the end there. Oh, it's 5:01. I'm so sorry.
No, thank you. That was a really good presentation, and I always enjoy your presentations that you give to the group. Thank you, everybody, for hanging out with us today. And thank you for participating. That makes such a big difference on these sessions, and I appreciate it. So our next upcoming session is going to be July 22nd, and it's going to be Just Say Now 2024, I believe, by Dr. Mark Garofoli. So I will see you all then. And I already have the slides from today put up so you guys will be able to see them. Thank you.
Thanks, Kelly. Thanks all.
Thank you, Katie.